Okay, so first of all, thanks a lot for including the paper. This is a joint work with Giada Bianchi from Harvard Medical School and Dongho Song from Johns Hopkins University. So in the economics profession, there's been quite a lot of discussion about the short-term trade-off between containing the COVID-19 pandemic and preserving economic activity. Like Jim Poterba just suggested, the economic profession jumped on top of this COVID trade-off. However, it seems to us there's been quite a bit less discussion about the potential long-term trade-off between economic activity and human well-being. In particular, what we are interested in is to consider the possibility that severe economic distress can also affect human well-being in the long run. And so what we would like to understand is the long-term impact of the COVID-19 related economic recession on public health. So to answer this question, we adopt a time series approach, and we use this to analyze the relation between unemployment, the death rate, and life expectancy. We do this for the overall US population, but also for groups organized based on gender and race. So in the literature, of course, many scholars have thought about the potential link between economic activity and human well-being. Surprisingly, there is no a consensus about the effects of unemployment on human health. And the reason why is because there are several channels through which unemployment can affect mortality and life expectancy. Compared to the existing literature, we take a time series approach, while many of these papers were more based on a cross-sectional dimension or panel regressions. And so this allows us to study dynamic relations between the variables of interest, but also take into account what we would call the aggregate business cycle effects of recessions. With respect to the literature that has focused on COVID-19, we cannot make justice to this literature. It's growing exponentially. So here we try to report that the papers are more closely related. I think the main difference here is that most of these papers focus on this short-term trade-off, and the papers that focus on more like long-term consequences of the pandemic, they're mostly focused on the economic consequences as opposed to the health consequences. That is the goal of our study. So to put things into perspective, let me plot the variables we are interested in. So here we have average life expectancy, the age-adjusted death rate, and then employment rate. We do it for the overall US population, that's the black dashed line. We do it for African Americans, those are the red lines, while the green lines correspond to the white population. So here, when you see a square, we're looking at women. When you see a circle, we are looking at men. So there are some very relevant stylized facts that probably the audience here is very familiar with. So there's been a general progress in healthcare, and this has led to an improvement in life conditions. Average life expectancy has increased over time. The age-adjusted death rate has been declining over time. African Americans tend to experience a lower life expectancy and higher mortality rates, but this difference has been declining over time, and we take this as an encouraging evidence. Nevertheless, the differences still persist, and also the differences still persist between women and men. When we look at unemployment, we can see that the African-American population has, in average, higher unemployment and also more volatile unemployment series. So what we are interested in is to try to understand the consequences of the evolution of these three variables for the COVID-19 recession. So what we do is that for each group I, so for the overall US population, and for each group identified based on race and gender, we're going to build a vector autoregression. So what that means is like we basically run an autoregression in the vector space, and the vector contains the growth rate of life expectancy, the growth rate of mortality rates, and the level of unemployment. We acknowledge the fact that life expectancy and mortality rates are likely to be observed with error. We don't observe the US population in continuous time. On top of this, it's quite likely that life expectancy and mortality rates are subject to what we call idiosyncratic short-term fluctuations. They are not really related to the subject of the study, that is the business cycle on the one hand, and possibly improvements in life quality on the other hand, for example, coming from medical progress. So to address this issue, what we are going to do, we are going to allow for an observation error in the level of these variables. So we take into account that perhaps what we are measuring is only a proxy for this deep component that characterizes the improvement in the quality of life. And then we estimate the model with Bayesian methods. So what that means is that we are jointly estimating the VR coefficients, but also these latent variables that represent life expectancy and mortality rates. In the paper, of course, we have all details about this procedure. The only thing I want to point out here is that we have priors on these coefficients, but these priors are symmetric across the different groups. So all the differences I'm going to describe next are going to be driven by differences in the data. So to give you an idea of what this filtering exercise, this joint estimation does to the raw data, here I'm plotting the growth rate of life expectancy and the age-adjusted death rate in the data. That would be the black line with the dots, and has filtered by our models. So what you can see that what this filter does, it removes these spikes up and down in life expectancy and death rates. They arguably are not really related to any secular change in healthcare or the business cycle. Once we have done this, then what we are interested in is what happens if there is an unemployment shock. So what happens if there is an increase in employment? What happens to the growth rate of life expectancy and the growth rate of the age-adjusted death rate? So we apply a Cholesky decomposition to find the impact of an unemployment shock. So what that means is that our basic benchmark identification strategy is that a shock to unemployment can affect the growth rate of life expectancy and death rates with a lag. So when we do this, you can see that we get a large increase and statistically relevant increase in the death rate and a decline in life expectancy. In the paper, we also describe the consequences of using a different identification strategy in which the unemployment rate can have a contemporaneous effect on these two measures, life expectancy and death rate. Qualitatively, the results are similar, so I'm going to focus in the interest of time on just on this benchmark identification strategy. So this is for the overall US population. We can do the same for the groups identified based on race and gender. So here again, the black dashed line is the overall population. So it's essentially the median of the impulse response I showed you a moment ago, while the red lines represent the African-American population and the green lines represent the white population. So on top, I'm considering the response of the life expectancy and death rates to one standard deviation shock. So as you can see, for African Americans, we have a substantially larger increase in the age-adjusted death rate and a substantially larger decline in life expectancy. Now, this could be driven in part by the fact that African Americans tend to experience larger shocks to unemployment rate. So you see this in the right column, you see that the shocks to the unemployment rate for African Americans are larger, and this is consistent with what I showed you in the beginning, that the series for unemployment for African Americans is more volatile. So to try to understand what is the relative role of the transmission mechanism versus the size of the shock, in the second row of this figure, I'm normalizing the initial impulse to be 1% for all groups. And so here some interesting patterns emerge. First of all, even controlling for the size of the shock, African Americans show a larger decline in life expectancy. When it comes to the age-adjusted death rate, however, the most striking feature is that for white women, the impact of the shock is substantially large. And this will become important later on when we will talk about the COVID-19 unemployment shock. Also for African-American women, we still have a large impact once controlling for size. So we can see that the differences get reduced once we control for the size of the shock, but they are still there. So far, what we have established is this historical relation between shocks to unemployment and mortality and life expectancy. So the next step consists in using this evidence to try to form a forecast about the consequences of the COVID-19 unemployment shock. So basically, the consequences of the economic distress on life expectancy and death rates. So this is already, in doing this, we already faced a data problem because on the CDC website, the data for the last 3 years are not available. So in order to do this kind of exercise, we need to treat these data as missing observations and try to infer the size of the unemployment shock just by looking at the series of unemployment and doing essentially a filtering exercise. So again, in the paper, we explain all the details, but essentially what you do, you back out the reduced form shocks, and then you use the same identification strategy based on the Cholesky decomposition to back out the COVID-19 unemployment shock. Once you do that, you can look at how the COVID-19 unemployment shock compares to the typical unemployment innovation. So in the first column here, the COVID-19 unemployment shock is measured in terms of standard deviations. So what you can see is that for the overall population is around 3.6 times the typical innovation to unemployment. But when we look at white women, this number gets at almost 5 standard deviations. So remember that white women typically experience smaller shocks than the rest of the population, but COVID-19, this has been well documented in the literature, but also in the press, white women have been particularly affected by this recession because of the type of services that have been shut down as a result of COVID-19. However, when we look at the absolute magnitudes, that would be the second column, we still see that African Americans tend to experience a larger shock. So just to look at this from a different perspective, what that means is that this recession is a bit more homogeneous in the way it has affected African Americans and the white population. But in relative terms, the white population, especially white women, have experienced an unusually large effect of the recession. So now that we have the size of the shock, we can move to try to form a forecast for the change in life expectancy and the change in mortality rates coming from the shock. So here, for each group in NBERs and for different horizons, we are looking at the percentage change in life expectancy. So I'm going to focus on just one particular horizon, again, in the interest of time. So let's focus on the 15 years horizon. What you can see is that the COVID-19 unemployment shock implies a reduction of 0.83% in life expectancy. So this corresponds to a decline of 0.65 life years. When again we look at African Americans, we see that these numbers get larger. And remember that they were starting already from a less favorable situation. When we look at the age-adjusted death rate, we find that, again, at the 15 years horizon, we have a 2.4% increase in the age-adjusted death rate. To put this into perspective, this corresponds to 18 additional deaths every 100,000 citizens. And now, again, what is striking here is that if we focus on women, African-American women and white women, we again see a very large increase, going back to the idea that they were subject to an unusually large shock. And on top of that, they seem to have a larger impact for a given size of the shock. Finally, what we can do is to try to translate all these numbers in what we call excess deaths. So now this is a painful, but nevertheless interesting exercise, because a lot of the discussion that we have around COVID-19 is in terms of excess deaths. So how can we think about excess deaths? Well, is comparing the outcome that we see as a result of the COVID-19 pandemic versus a counterfactual that basically asks what would be the number of deaths if COVID had not occurred. So we can do a similar exercise, but instead of doing for the number of deaths in 2020, we can do this looking forward. And in particular, we can do it looking forward as a result of the unemployment shock. So we can basically ask, what is the number of deaths with the unemployment shock that we have experienced versus a counterfactual in which the unemployment shock had not occurred. Now, this exercise, it's actually more complicated than what it sounds, because essentially what you want to do is to reconstruct the path for the population to take into account that people essentially cannot die twice, okay? So what you want to do, you want to adjust the path of the population with and without the unemployment shock. So we take the census projections as our benchmark, as how things would have been without the COVID-19 shock, and then we reconstruct the population path using this change in the death rate. An additional complication is that we want to translate age-adjusted death rates to crude death rates, and we do this based again on the historical correlation between these two variables. What do you get in the end? Well, in the end, you get that if you look at the 15 years horizon and the 20 years horizon, you get excess deaths in the order of 0.8 million and 1.2 million at the 15 and the 20 years horizon. Not surprisingly, given that we are trying to forecast something 15, 20 years down the road, there is a lot of uncertainty, but we think that these numbers are big enough that make you pause and think.
Francesco, about 5 minutes.
Perfect, thank you. When we look at the African Americans, the number are 200,000 and 290,000, so almost 300,000. And just to give you an idea, this means like around 0.4 and 0.5% of the projected African American population. When we look at the white population, we find excess deaths in the order of 0.8 and 1.1 million, again at the 15 and 20 years horizon. And when we put that in relation to the projected population, we find 0.3 and 0.4%. So again, here you can see that the numbers are painful for all groups, but they seem to be, in terms of population, a little bit larger for African Americans. And again, you can see that if you focus on white men versus white women, there seems to be a larger impact for white women. And I want to stress that this is the result of two features. First, that for a given size of the shock, white women seem to have a larger increase in mortality rates. And second, that this recession affected particularly women, both African American and white. Okay, so before concluding, let me give you a brief discussion to put these results into perspective. So sometimes this paper gets interpreted as we are advocating against lockdowns. I want to clarify that we are not epidemiologists, so we trust their judgment. It's not our job to decide how we should contain a pandemic. So there are recent studies that show that in the US alone, more than 100,000 lives were saved out of lockdowns. So that's the first thing I want to clarify. Second, this is a study based on historical data, and there is no shame in that, because there is not much else we can do than learning from the past to try to understand the future. But what that means is that there are a series of factors that could make these numbers better and a series of factors that could make this number worse. For example, the economy could recover faster than in the past. Maybe a shift in economic and social policies could reduce the duration of the recession and the severity of the recession. This is also the first recession with the Affordable Care Act. So what that means is that people might still have access to some form of health care, even if they don't have a job. These are all factors that would reduce the impact of the shock. On the other hand, limited access to health care, the temporary discontinuation of preventive care, the loss of employer-provided health insurance, the fact that many people are fear to get sick, and so they might be reluctant to seek medical advice, might make these numbers worse. So conclusions. So we find that unemployment shocks can have a long-lasting effect on life expectancy and death rates. Based on this historical pattern, we forecast that COVID-19, the toll in terms of deaths of the COVID-19 might go well beyond what we see today through this additional channel that is economic distress. Of course, there is an entirely different channel that is the fact that COVID-19 might also have some long-term health consequences. That's something to consider that we don't really study here. The shock will disproportionately affect African Americans and women, while the effect on white men seems it will unfold over a prolonged period of time. Our results imply that the trade-off is not only in the short run. If we want to reduce the number of deaths, it's definitely important to understand how to contain the pandemic, but also to provide policies that can help human health in the long run. So if the final goal is to reduce the number of deaths, essentially you need both kinds of policies. Thank you.
So I'm assuming that everyone can see my screen. If not, please just let me know. So I just want to start by saying a very big thank you to the conference organizers for this this conference, and in particular for inviting us to talk about our paper, which is going to be on the value of communication during a pandemic by looking at the case of COVID. This work is joint with Belinda Archibong, who is from Barnard College. So basically, to give you a sense of the roadmap and where all of this is going, I'm going to start by motivating what really gets us really interested in this question, and then talk about the setting and the design, present the results, and then we can conclude with some discussions. And if there's time, I'll delve into the connections to the literature. Okay. But to get things started, I just want you to simply imagine. I mean, I know not a lot of us can imagine that, but in a much more refined world, imagine that you are not able to communicate during these COVID times. But what do I mean by that? I.e., I mean that it's it's very difficult for you to make a phone call, use the web, access social media, and many other allied communication channels when the unexpected need arises. The key question we're going to try to get at here is whether there's such unmitigated, what I call unmitigated communication barriers really matter, in particular during a pandemic. Does it matter for individual, psychological or economic well-being? And if we were to think of, communication programs that hopefully allows us to mitigate such barriers. How should we design those programs? Should it be a one-time large transfer, or should it be some, installment packages that allows individuals to smooth their communication over time? And I want to say that, also mention that this whole big, kind of question we're trying to get at is kind of motivated by three fundamental facts. The first fact is that, again, if you look all around the world, there've been, a remarkable number of communication interventions or programs that have been initiated in response to the arrival of the COVID-19 pandemic. So let me start from right here in the US. I mean, as you can imagine, so right at the beginning of COVID, somewhere, in March and in April, AT&T actually, gave a free 10, gigabyte of internet data for all its, eligible customers. And in part, this was really important for those people who didn't actually have really better access to the internet. Well, going to my context, so in Ghana, where I'll be basically looking at, as far as my presentation is concerned, the government actually, in response to that, actually reduced the communication services tariff from 9% to 5%. Again, with the goal of trying to make, communication more fluid and easily accessible. Again, coming back to the US during Thanksgiving, Zoom was so wonderful in providing us what they call hashtag Zoom together. And the goal was to actually get people connected and be able to stay connected, right? Throughout the pandemic, whilst they enjoy, this, distant, celebration as far as, Thanksgiving was concerned. So in the paper, we provide a leadership, role in terms of providing probably one of the first, global reviews in thinking about what the space of these programs, although impartial, but really, very compelling to look at the wide range of programs that have really been enacted in response to the COVID-19 pandemic. And the simple message there is some of these programs are one time, some of them persisted for some time, and it could vary at different levels coming from the government, private institutions versus different sources. So we're going to argue actually, as far as this paper is concerned, that these kind of programs, we're going to argue is particularly really important in developing country settings where actually the informal sector is pretty large, likely hit by COVID. And actually COVID, the pandemic really threatens individuals who are really, faced by what I call internal constraints. By that, I mean people who are faced by credit, by income, by savings, and even by psychology. And there's a lot of literature that speaks to this. Well, despite all these remarkable programs that are prevailing within the space of, pandemic, we have literally no understanding about what the potential impacts of such programs are. Okay, so that's the first fact. The second fact, again, is very congruent with the first fact. If you look at administrative data, detailed administrative data from the largest, telecommunication, company in the context that we are looking at on mobile financial transactions, it basically demonstrates or eliminates the potential value of communication during the pandemic. Well, two fundamental facts. If you look at the data, the overall market activity was going down. Mobile financial transactions were going down, as you could think, because of the depressive nature of COVID. Well, what we do find in turn, the opposite rather, in contrast, is that the demand for mobile airtime, which again, you could think of as the purchase of airtime during these COVID times, was going up. So whilst everything was going down, purchase for airtime was going up. Again, try to illustrate how important, communication is in part in this context. Well, it turns out the second fact is also congruent with some baseline surveys that we did to motivate our paper. So we carried out a very comprehensive baseline COVID survey across low-income, individuals in Ghana. And in fact, look at what we find. 68% of the subjects that we spoke to actually indicated that their need to call family, friends, and employers actually have increased due to the COVID disruptions. But look at the contrast. Yet about 52 to 62% actually indicate that sometimes they are unable to meet such communication needs when the need arises. Again, really speaking to the potential value of communication, yet the fact that there could be binding communication barriers during the pandemic. So you would think that combining all these three facts, programs or what I call communication programs that would directly mitigate these potential unmitigated communication barriers will likely have impact on welfare. And by that, I'm going to talk about psychological welfare and then economic welfare. Just to give you a sense of what I will tell you, in case folks aren't able to stay throughout my entire talk, although it's a pretty short one. So we're going to try to get at this question using a field experiment. Okay, so let me tell you about. So we designed and basically fielded two potential communication programs. In one arm, we have what we call a lump sum, mobile calling credit arm, where essentially we calibrate that, again, 40 Ghana cedis, which is the equivalent of $7 is equivalent to meet the most basic communication needs during this time, looking at the data. So we have one group of people that receive this 40 Ghana cedis lump sum. Then in another program, just to benchmark this lump sum transfer, communication transfer, with a program that has just 2 installments. Basically, they receive it, once per month for just 2 times. And of course, we have a peer control group that did not receive any of these communication transfers. And we deployed basically these programs on a nationally representative set of low-income individuals in Ghana. And I'll speak to that very briefly about how we got to this. So in terms of results, again, as a first stage, we find a remarkable decrease in people's inability to meet these communication barriers. Well, what do I mean by that? So the interventions basically help the subjects, the beneficiary subjects, basically mitigate all potential barriers that they couldn't have really mitigated in the absence of our programs by almost 44 to 78% relative to what a pure control group. Well, you think that this is what you'd expect, right? You give out this stuff. Well, as a result, we do find really meaningful impacts on welfare, in particular on what mental health. So what we found is that the program relative to the control, individuals in the treated arms actually had mental distress. Again, mental health is going to be measured using mental distress. Mental distress really went down by roughly 10% relative to the control group. Severe mental distress, which is again the severe version of mental distress, actually decreased by almost 26% relative to control. We do find some traction, some effects on domestic violence or intimate partner violence. Again, individuals, so the treated individuals were about 6% less likely to threaten their partners. But this does not really translate remarkably into they may be reducing the incidence of hitting their partners during the times that we look at. Well, we do not find much impacts on economic well-being. By that, I mean the impacts of our interventions on consumption expenditures was essentially zero. We take this as a reassuring evidence because, again, these transfers are very low cost, small packages to the extent that they couldn't really trigger large changes in consumption patterns. One fundamental, again, result that I think we're going to speak to as far as policy is concerned is that the installment credit program seems to have larger and more sustained impact as compared to the lump sum programs, which is really key in thinking about how to design these programs during pandemics. So let me tell you a little bit about the setting. So the study is going to be set in Ghana. Ghana is located in the western part of Africa. And this is a country with a very high mobile subscription rate, according to the World Bank, of about 134%. Well, this does not mean everyone has a cell phone. It simply means that you could take an individual who has multiple cell phones. So subscription rate is almost about 134%. And we're going to draw basically on a nationally representative baseline files with our research partner, which is the Ghana Census Service. So basically, this is the survey arm of the government, the institution of government that really, this is like the BLS version of the US, okay? So they collect, all these, sample frames of individuals. So we draw on previous data from what they call the Ghana Living Status Survey 7. And basically, we're able to narrow down based on some previous exercise that we have done to individuals that were located in basically the bottom 75th percentile of the income distribution. So we're going to focus on people in particular who stand a chance of being poor by almost 22% of the time, at least, and we're largely married so that we can get at these domestic violence issues. Well, I don't think I need to motivate pandemic, COVID in particular, because again, we have all been part of it, and we still live in it. But just as, in every other country, or just as in the US, Ghana actually also, the COVID-19 triggered a lot of economic impacts, negative impacts in particular, well beyond the potential health impacts, that you might think about due to the restrictions on mobility and human or social interactions. So on March 30th, the government of Ghana, Nana Akufo-Addo, actually introduced a lockdown in the 2 most economic areas in Ghana, or 2 most economic regions in Ghana, which is Accra and the Kumasi metropolitan areas. This was later followed with a nationwide lockdown, basically closure of all schools and a ban on other social activities. So during this time, again, intercity travel, so traveling from one city to another, except for essential services, was entirely suspended. Within the city, intracity travels, actually vehicles have to reduce the number of passengers they carry to observe social distancing. As of April 20, the lockdown was removed. Some of the restrictions were relaxed, yet individuals continue to battle the impacts. Again, this has been revised and there are recent restrictions that have been introduced. So one nice thing about setting that nearly 100% of all subjects have indicated that they are aware of COVID and the potential economic disruptions that this is really having on their lives, which is very necessary, but not sufficient for our work. So to motivate our work, so let me show you a little bit about the timelines and when the interventions came in and how all these things were deployed. So what I'm showing here is basically the evolution of our survey exercise. So this really started somewhere between October, September, and then November, we introduced the first intervention, which basically is a combination of the first tranche of the installment program and then the lump sum. And then towards the end of November, again, we introduced the last tranche of the second communication program in the installment program. So just to motivate our interventions, we started with almost 3 different waves of baseline data analysis, basically to motivate and combine this with administrative data from providers to get a sense of what is going on as far as communication is concerned. So again, this is to highlight the fact that it's been it's a panel wave that basically stretches from all the way from October to December. So as far as our interventions is concerned, we set the total value of our transfer for each subject to about 40 Ghana cedis, which we calibrate using administrative data and the changes in communication patterns during the pandemic to be enough to at least mitigate or take care of basic communication needs for at least a span of 2 months. So we employ basically a 3x1 or 1x3 factorial design, randomizing these representative subjects into our 2 treatment programs and one peer control. So in particular, we have about 376 individuals in the lump sum arm, and then about 371 individuals in the installment program, whilst the rest were in the control program. So to do this, again, we had to do a lot of partnership with outside the government arm, which is the Ghana Statistical Service. We had to partner with a major telecommunication company in Ghana to deliver these mobile credits. This is basically to highlight, how we measure these outcomes, because I think it's going to be useful in thinking about, the interpretation of our results. So let's spend a little bit of time on that. So the first point of the first stage results, which is to get at whether our programs were really working. So we started by thinking about how do we measure, mitigation of communication barriers. Okay. So again, we started with a whole bunch of questions, asking subjects whether they unexpectedly experienced the need to make a call or connect with others, but they were not able to do that just because they simply lacked enough resources, communication resources, to remedy the cost. Right? So that is kind of our first benchmark. We also narrowed down even to whether they actually, because of COVID, they didn't have enough communication resources to remedy those costs. One thing and one common thing that you find within this space of environment, by the way, this is a pay-as-you-go environment. It's unlike in the US where you have a cell phone plan and you kind of get your bill towards the end of the month. You pay as you go. So one thing people do is that they tip in dire situations like COVID, they appeal to borrowing what they call save our soul airtime. So these are really, high interest bearing, airtime that you can borrow from the telecommunication companies. And typically you don't even get approved for that, or you need to fulfill some usage patterns before you're allowed to do that. In addition, they also seek for this new wave of credit, which is delivered on mobile platforms called digital loans. Again, very close to the market for mobile money due to these unexpected circumstances. Again, so we try to get at people's likelihood of borrowing SOS airtime along with seeking for digital loans. So that's going to be the first set of measures to get at how we are really mitigating the impacts of communication, unexpected communication. The second is getting at the welfare outcomes. So we started with the economic outcomes, which is going to be on consumption expenditures. So looking at about 8 different items. So 7 is listed here. Food expenditure, we have food inside the house and food outside the house. Talk about utilities, personal care, education, health expenditure, all the way down to durables.
Francis, try and finish up within 5 minutes.
Okay. In 5 minutes? Okay, great. Yeah. I think I can do that. So, mental health, we're going to appeal to the psychology literature and try to get at mental health outcomes, typically measuring mental health using what they call a Kessler, psychological index called K10, which takes values from 10 to 50. And then we're going to define mental health basically as the extreme version of mental health, looking at K10 values that are above 30. And again, we then directly elicit, subjects, basically whether they really, intended to they hate their partners or threaten to hate their partners for the past 7 days, depends on the wave. So these are the results. The results are basically, I'm going to report different set of results. One thing I want to emphasize is going to be a standard treatment effects framework. We take inference seriously, we take attrition seriously, and then we also take, this modern economics, literature and thinking about transparency in terms of, experiments. So we're going to report combine machine learning with treatment effects to demonstrate that our results are really not subject to p-hacking and a whole bunch of other stuff. So let me show you the first stage results. So what we are showing here is that the communication programs actually led to a remarkable decrease in individual subjects' experience of unmitigated communication barriers. In particular, again, I've walked you through these outcomes before, so again, I can skip that, but basically we find that there's a large decrease of about 44 to almost 78%, depends on which outcome you look at, in terms of their inability to meet communication barriers relative to the control. If you look across the trajectory, the effects are larger for the installment program relative to the lump sum. So let me, again, just reaffirm, again, I've projected these results before, but this is basically a slide that shows the impact of the communication programs, the real impacts on actual well-being outcomes. So again, across the two, treatment programs, the lump sum and the installment program, we find that, again, for mental health, which is basically the log K10 measure here, decreased by almost 10%. Severe mental distress decreased by almost 2.7 percentage points. That translates to about 26% reduction relative to the control. We do not find any impact on direct consumption expenditures, which again is not surprising. We do a lot of, to understand these effects, we try to benchmark this with what is really, how do our results really operate? We find evidence of what large impacts on the very poor, people in the informal sector, people who are located in the more lockdown areas, and less impacts on less differential impacts by gender. So to conclude, the COVID-19 pandemic actually really revealed a lot of economic and mental health crises, in particular for people who are bound by some of these internal constraints, by savings, by credit, and by psychology. We provided first, again, experimental evidence on the impact of providing simply very low cost communication transfers during the pandemic, yet with remarkable impacts on mental health. Again, we've shown that this program really matters for communication, matters for, again, mental health, but less impact on economic outcomes. One conclusion is that the pandemic really has triggered a lot of programs. This really might be doing a lot of, benefit as far as psychological well-being is concerned, less so for economics. Again, I'm just going to stop here. No time, but we contribute to a lot of literature that we can all appeal to. Thank you.
Okay, good. So, thanks a lot for the invitation. This work that I'm going to present is joint work with Randall, Akee and Emilia Simeonova, who are also joining us today. And I wanted to start saying that we have all witnessed how the COVID pandemic has affected all aspects of society pretty much, including, of course, our relationship with health and health services that go beyond the mere impact of treating COVID patients. And so even though it's been talked about, especially at the beginning of the pandemic, as something that would make COVID the great equalizer, the impact has by no means been homogeneous. And so, let me see if this moves. But soon after the pandemic started, we realized that racial minorities were overwhelmingly affected by it. American Indians in particular showed death rates of 1.5 times and infection rates of 3.5 times those for non-Hispanic whites. Healthcare utilization was different among reservation inhabitants even before the pandemic. And the incidence of low density and infrastructure scarcity motivates the question of this paper, which is, were these populations affected differently in their healthcare usage by the lockdowns? A word about lockdowns. They have been widely studied. As Francisco mentioned today at the beginning, it is difficult to do justice to the large body of new literature looking at the impact of lockdowns in different aspects. But I would say that a fair summary is that in general, they show that they reduce movement and reduce social interactions significantly. In recent related work that I have done with Emilia too, we find that these lockdowns reduce on average traffic by 40%, and that they induce further voluntary social distancing, not only as a reaction, voluntary social distancing that can stay even after these are removed. And there's other evidence that shows that this social distancing as a consequence of these NPIs, these non-pharmaceutical interventions, have been effective at reducing cases. So this here. So as mentioned before, reservations were acutely affected by COVID-19, especially those with worse socioeconomic indicators. For example, also in related work to this one with Emilia and Randall as well, we have shown that COVID-19 had some unexpected effects on nutrition by reducing the access to healthy food in supermarkets in some of these reservations. In this work, we also look at the effect on reservations, but specifically on healthcare. The closest work we could find was work by Zidan, Simon, and Wing, in which they analyze healthcare records, electronic healthcare records, and they find that lockdowns indeed affect the utilization of elective healthcare services, and that some like mental healthcare were partially replaced by telehealth. And they find that reopening or lifting of lockdowns increases utilization, but does not bring it back to pre-pandemic levels, right? Which is consistent with this idea of voluntary social distancing remaining active even after these closures have been removed. So we contribute to the area that the Zidan, Simon, and Wing study started, analyzing whether there are any differential effects of utilization by inhabitants, specifically Native Americans living in reservations. Instead of electronic health records, we use phone mobility data to capture visits to healthcare facilities. And to compare to that work, we lose some level of detail about the specific purpose of the patient visit to the healthcare facility, but we gain in terms of solving some of their local representativeness issues in the data. And we also get a very accurate idea of the location of the home of the patient. So, regardless of where the hospital is that they visit, we know exactly where they live. And given that data on healthcare utilization are very hard to come by, especially on short notice and high frequency, we believe that phone tracking is an excellent resource to address this question. This table here highlights the lower access to healthcare facilities that you find when you compare reservations in the US with all the locations that are off reservations, right? So with different types of facilities, we find that they have lower numbers in terms of availability per 100,000 inhabitants. We also see that people in reservations have to travel longer distances to visit these locations. And see, these longer distances are an even more important indication of availability, because regardless of how many units or how many facilities they have nearby, we see that a lot of them need to travel farther away. For instance, there is around 8 fewer outpatient care facilities in reservations per 100,000 people than off reservations. And in reservations, people have to travel on average 1 mile longer to get to these facilities. Okay, about the data, as I mentioned before, we use mobile phone data. It provides, very high and comparable coverage inside and outside of reservations, which was crucial to be able to answer a question. In terms of the NPIs, the non-pharmaceutical interventions, we focus for all the areas that are outside of reservations. We focus on county and state level lockdowns. For reservations, this is a little bit more difficult because reservations are not subject to the county or state implemented lockdowns. Lockdowns took mainly the form of casino and related businesses closures in reservations imposed internally by tribal authorities. These were the main tools to reduce social interaction and contagion. And so that's what we use for reservations. Fortunately, in our data, most locations in and off reservations show at least one closure, one lockdown implemented, and one reopening. We have data up until the end of the summer in 2020. So that allows us to study both the effect of closure and of the reopening. We will use a diff methodology to estimate the effects of these closures and reopenings on healthcare utilization related variables. Our diff setup is standard. We have two treatments, the closure and the reopening of the economy, which we call here NPI lift. And today I will focus mainly on the results on the number of visits, but we have also analyzed other variables like distance traveled and visit duration. One thing that is important here is that how to assign the NPI or the the closure and stay and lockdown. So the way we do it in two approaches, right? The first one, we simply allocate or assign the NPI, the lockdown, to the location of the healthcare facility. In another one, and I'll show you which one, how they compare. In another one, we actually look at the impact, or we allocate NPI or closure to the location of the patient's home. We know where the patient lives because we can track their phone, and we determine the home location. And so that allows us to contrast both demand and supply driven disruptions. And we include data from 2019 and a week of the year dummy. So all the coefficients that you look at here are comparing outcomes between the pre-pandemic results in 2019 and the current time under the treatment, right? So they should all be interpreted as a comparison to pre-pandemic times in the same location. Finally, we include also an interaction with a dummy that determines if the location of interest is in or outside of reservation. The coefficient with these interactions determines if the effect of the treatment is different for reservations. And so an insignificant coefficient for the interaction with the reservation dummy does not necessarily indicate no effect. Instead, it indicates that the effect is indistinguishable between the locations inside and outside of reservations. All right, so let me double check how much time I have. Jump to the, all right, jump to the results. This first table shows results for the categories that we considered among the ones that we are analyzing the more essential. So maybe I missed showing you that, but we are analyzing visits to general medical and surgical hospitals, kidney dialysis centers, outpatient care centers, pharmacies, skilled care services, and specialist office. So here we have the results for the ones that are more essential. The first thing that we notice is that NPIs did indeed reduce healthcare utilization, right? So when you look at the coefficients here, you find that visits to all of these locations, including places that are considered very essential like dialysis centers, were reduced as a consequence of the NPIs. Then the next thing we see is when we look at reopenings, right? We see that there is an increase in visits. There's a recovery, especially, for example, in the case of dialysis centers, right? Shown by the positive coefficient in the first two columns. In other locations like hospitals, you actually see that there is no significant recovery, but the fact that the coefficient is lower than the coefficient on the NPI suggests that there is indeed some recovery, but that it's not a full adjustment to the levels of 2019. In hospitals, as I said, specifically, there's not a catching up on delayed services, which is a very interesting question, whether people were just delaying optional care, and they were going to show a more than usual demand for these services. When we look specifically at the differential effect on reservations, we see a more muted effect for hospitals and outpatient care facilities as a result of NPIs. So these two services are considered less essential than dialysis. In terms of dialysis, depending on how you measure it, you see no additional impact, but again, no additional impact, for example, in the case of this coefficient, should be interpreted as reservations behaving in the same way as of reservation locations. In this case, seeing a catch-up effect, right? And more than proportional recovery of the usage of dialysis centers. Overall, when you compare the coefficients, what you find here is that there's a weaker reaction in reservations to the NPIs, right? Both the decline is lower and the rebound is lower in reservations, which suggests either that the NPIs were less stringent in reservations, or it could also suggest another dynamic that I think is more interesting and is consistent with the initial table I showed you of lower availability of these locations. And that is, if given the low availability of these services in reservations, it could be the case that people were mainly visiting healthcare services when these were essential visits, when it was extremely urgent or serious to avoid going to the doctor or to the hospital. And so in that sense, we're looking at a type of usage that is less elastic, right? Whereas maybe there were a lot of elective procedures being performed outside of reservations, and so the demand was more elastic, therefore explaining in a way why the reaction was stronger outside of reservations. These other table shows results for less essential locations, pharmacies, skilled care, and specialists. And the results overall are similar. I guess I will point out that for all of these elective procedure, or for these less essential locations, maybe it's a better term, you see that the utilization was significantly lower in reservations even before taking into account the NPI, imposition or lifting, right?
Luis?
So overall, they are using, yes.
5 minutes.
How much time?
5 minutes.
Okay, thank you. Great. Okay, so other than that, let me see these results. We find that NPIs were effective also in reducing usage of these facilities. There's some rebound, and it's specifically strong in places that were less essential, like pharmacies, and again, weaker reaction in reservations, right? So the way to interpret again these the final effect on reservations is to add the effect of NPI, for example, on the effect of the interaction, and you will see that in both cases they seem to be working in opposite sense. We have results for dwelling time and distance, and here I won't go into the details, but what we find is that in general, reservations travel longer distances. They have a very hard time readjusting when NPIs are imposed. And during lockdowns, in general, visits get longer, which we interpret as more serious cases only visiting the health facility and maybe staying longer for treatment. Okay. All right, so to conclude, overall, we see lower access to healthcare facilities in reservations. This is true both when we look at just the availability of the services, and also when we look at the distances that people have to travel. When we focus on what was going on before the pandemic, we also see that there's fewer visits even when after controlling for population. So this could suggest that utilization for reservation dwellers might focus on essential care. And this could be consistent with a lower reaction to closures and reopenings in reservation, which is what we get from our analysis. So reservations might not be delaying elective care because they were not getting elective care in the first place, but more essential care. And then finally, you know, I think I mentioned this before. Due to reopening, some facilities show catch-up behavior, but show much less than full adjustment, indicating reluctance to social contact. And in terms of two issues that we are, currently studying that arise from our results, one is the potential impact of lower access to telehealth. So as Francis presented, communication plays a very important role. And in this case, it could play a role of substituting visits to healthcare facilities. So we're studying if that could be a possible mechanism that explains the difference, especially when we have observed that access to high-speed internet is lower in reservations. And finally, reservations show lower elasticity to travel costs imposed by the pandemic in dialysis centers. And we think that this could indicate lower availability of home hemodialysis services. And so it would be interesting to study that as well.
Much. And first of all, thanks so much for the organizers for giving us the opportunity to present our project on social networks, shape beliefs and behavior, evidence from social distancing during the COVID-19 pandemic. This is the newest in a series of papers that Mike, Johannes and I have on the effect of social networks. And here we study social distancing together with Johnston, Martin Koenen and Dominic Russel. Some of my co-authors should also be on the chat to answer questions as they come up. So this paper has been motivated by the ongoing global COVID-19 pandemic. And we've seen basically for a year now, these persistent appeals for people to social distance and to mask and stay apart to contain the pandemic. But we also see that there are huge differences in compliance with and also in support for these social distancing policies. And so what we want to study in this paper is what contributes to this, what shapes people's beliefs about the pandemic and their subsequent social distancing behavior. Specifically, what we do in this paper, we study the role of social networks. And so what we do is we use individual level de-identified data on both social networks and mobility from Facebook to show two main findings. The first finding is that social network exposure to COVID-19 shapes distancing behavior. Specifically, individuals who have more friends in areas with more COVID-19 cases, they reduce their mobility more, they engage more in social distancing. As the pandemic progresses, we see that changes in friend exposure affect changes in mobility. And this effect in general is not driven by the French ability to work from home, but seems to be a choice in voluntary social distancing. Then in the second part, we want to better understand what drives this effect of friend experiences on social distancing behavior. And so we look at beliefs and opinions that people hold about COVID-19 and the imposed restrictions. And what we show is that if people have more friends in areas with more COVID-19 cases, they are more likely to post about COVID-19, suggesting they are more aware. They post less about opposing social distancing relative than supporting it, and they're less likely to be part of reopened groups, suggesting that overall, this friend exposure to COVID-19 shapes people's beliefs and opinions that they express on Facebook about the pandemic. So let me tell you a little bit about the data that we use to reach these conclusions. We have anonymized network data from Facebook. So this tells us each individual's friendship links as well as the location of her friends. So we know for each person where she has friends and where these friends live. We also have some individual level location and characteristic information. So most importantly, we know the location of that individual herself, and then we have some demographics like her age and her gender. We also on Facebook have information on mobility. This is available for a subset of users who have location history settings, which means they allow Facebook to track their location history. And so we use two measures of mobility. Our main one is whether they stay in their home tile. A tile is about a 600 by 600 meter square. And so we see whether they leave that on a given day. We also have an alternative measure where we look at the number of tiles that they visit on a given day. Finally, for these people in our sample, we observed their public posting behavior as well as any public groups that they join on the Facebook platform. Okay, so here's a first look at just mobility over time. This is literally just the raw data, the time series. And what you see here is that starting in mid-March, which is when the pandemic really hit the US and a national emergency was declared, the likelihood of an individual staying home just really jumps up from about 18% to like over 30%. We see really the same picture when we look at our alternative measures, the tiles visited, where we see that the number of tiles that people visit goes down dramatically starting in mid-March by like 40%. What I will do now, I will focus on this measure of staying in the home tile, but everything you see also holds in this alternative measure. So now our first key question is, do people who have higher friend exposure to COVID cases, do they engage more in social distancing? For this, we need to measure friend exposure. We first measure friend exposure at the onset of the pandemic as of March 15, which is the day when President Trump declared a national emergency. And so friend exposure is the friend-weighted measure of COVID cases on that day. Basically, we take the fractions of friends someone has in each location and multiply that with the number of cases in these locations. So of course, now you might be worried that it is correlated with other characteristics, that people who on March 15 have more friends with exposure to COVID, at that point it was basically Seattle and New York City, that they might differ on other observables. For now, I will just want to show you a little bit of raw data, but I will do everything within the same zip code. So I'm going to compare people who live in the same zip code. We will then add controls for observables, and we will move to a change on changes specification, and things will go through. I just want to show you all these things. So here's the first just raw cut of the data. We divide people into two groups. We determine whether they are above or below the median in friend exposure to COVID cases within their CCTA, so within their zip code, and we plot mobility over time for these two groups. So here's what you see. And what you see is that in the pre-period up until early March, the two groups have really identical baseline probabilities of staying home of around 18%. Starting in mid-March, for both groups, the likelihood of staying home increases dramatically, but there's like this really strong divergence. So people with above median friend exposure relative to others in their zip code stay home about 34% of the days in April, May, whereas for people with below median friend exposure in those same zip codes, they stay home on less than 32% of days by mid-April, May. So far, this was just pure raw averages in the data. And of course, there's a huge concern for differences in other observables between high and low exposure individuals. So now we're going to repeat the same analysis, but we're going to estimate the coefficients, including the following controls. So we include individual level fixed effects. So this controls for baseline differences in mobility between different people. We also allow for time varying effects of individual and location characteristics, namely whether a person went to college, their age, their gender, and whether they have an iPhone or a tablet, as well as their zip code. So if people in a given zip code, everyone behaves differently in certain weeks, that's going to be accounted for. We also control for some time varying effects of other network characteristics. So same way that we calculated the friend-weighted COVID-19 cases, we calculate friend-weighted median income in the locations that someone has friends, as well as population density and how urban these areas is, so that we're not just capturing connections to big cities, high population density areas, or to rich cities. Controlling for all these are the estimated coefficients, and you see that we have these still like very flat, basically zero pre-period of no differences. And then in mid-March, people with above median friend exposure, they stay home more, specifically up to 1.2 percentage points, which is an increase of 3.8% relative to the average of staying home 32% of the days for the below median average group. And you can also see that there's pretty high precision for these estimates, so these are highly statistically significant. I also want to mention that this doesn't seem to be a difference in the ability to work from home. So we separately estimated in the paper these patterns for weekdays and weekends, where you would think most people don't work on weekends. So if it is a differential ability to work from home, we would expect much bigger differences on weekdays. We don't see that at all. We have another specification where we just estimate within a fixed effect for people who are same age, same gender, but also went to the exact same college, because we think that also proxies for the type of jobs they might have and therefore their ability to work from home. And again, we see no differences, suggesting that it's just not driven by this differential ability to work from home. Okay, so far I showed you friend exposure at the onset of the pandemic. But you might still be worried, despite the controls we include, that this is correlated with unobservable differences between people. So what we're going to do now is we look at, as the pandemic progresses, whether changes in friend exposure affect changes in distancing. And this is quite helpful because the early and the subsequent hotspots of the pandemic differed substantially. And that also means that the correlation with observables of our friend exposure measure varies over time. For instance, at the onset of the pandemic, when it was mostly Seattle and New York, it was the case that people who went to college had higher friend exposure to COVID. So there was a positive correlation. But as the pandemic progresses and as the hotspot moves to Louisiana and the Dakotas, then this correlation actually flips. And it is the people who didn't go to college who have a higher friend exposure to COVID-19. And so what we're going to argue is that it's quite unlikely that there is an unobservable characteristic which varies over time in the exact same way that the pandemic spread geography through the United States. So you can see this here on the map. On top, you see March, February, and then April, March to April, April to May, and May to June, and you can see how the exposure just changed. It moves from New York and Seattle, like those areas with high educated people, to the south, and then actually at some point the Midwest has the highest friend exposure. Okay. So we exploit this to estimate this relationship, where we look at changes in mobility on changes in friend exposure. Again, we have the controls for individual level characteristics for the other network exposures to high income, high population density, high urban areas. And we also allow them to vary by month, so to the extent that they might be different. So what you see in the first two columns, this is pooled over the entire spring and early summer, is again that friend exposure increases the probability of staying home, and even including individual level fixed effects. So really just estimating of changes for the same individual, we find very comparable magnitudes, suggesting that these unobservables are unlikely to drive our result. When we do this by month, we also see that changes in friend exposure in the same month affect changes in behavior in that month. So if you look at June, changes in friend exposure in June really explain behavior changes in that same month. There are some small effect for earlier exposure changes, but really it is the same month that has the biggest coefficient, the biggest predictive power, again confirming that it is the contemporaneous friend experiences that shape contemporaneous behavior. Okay, so far I could hopefully convince you that individuals with higher friend exposure engage in more social distancing. So the next question is, why is that and what's the mechanism? So now we want to understand the mechanism better, and specifically we want to understand whether these people engage more in social distancing because exposure to friends and their local COVID-19 cases makes the risk more salient and makes them support social distancing measures, more belief more in the dangers of maybe becoming infected. So we look at 4 outcomes that capture these beliefs or opinions about COVID-19. We look at whether people post about COVID-19, whether they are engaging with the topic. Conditional on posting, we look at whether they oppose or support social distancing measures. We also look at the general sentiment of all of their posts, whether it tends to be more positive or more negative. And finally, we look at membership in so-called reopen groups that advocate reopening the economy. As before, we control for other network exposure fixed effect and for interactions of location and individual characteristics to really compare similar people in the same location and their behavior. Our first outcome is the share of all posts that are about COVID-19. And you see here this relationship between the friend-rated cases that someone has and their share about posts about COVID. And there's pretty strong, relatively linear relationship between higher exposure to COVID through friends leads to more posts about COVID-19. So just in terms of magnitude, if we doubled someone's friend exposure, the share of posts about COVID would go up by 17 percentage points, or just under 10% of the baseline probability of posting about COVID. Next, we want to see whether people who post about COVID, whether they support or oppose social distancing measures. And so we classify all posts by analyzing the language in the posts as supporting social distancing measures, opposing them, or just not taking a stand or not being about this. And so now we
sorry.
Yeah.
5 minutes.
Okay, perfect. That works well. So we capture whether you oppose social distancing by the fraction of posts that are opposing social distancing as a fraction of all of the posts that are signed that either support or oppose those posts. And what we see here is, again, this relationship between higher friend exposure to COVID-19 shows us that people are less likely to have a post that opposes social distancing. They're more likely to support these restrictions and social distancing measures. For magnitudes, again, if we double friend exposure, the share of signed posts that oppose social distancing goes down by 1.3 percentage points, or that's just under 4% of the baseline. So after looking at the posting behavior, we have 2 more measures of people's sentiment and beliefs about COVID. The first one is a general sentiment measure. So this is a measure that comes from the natural language processing literature that just captures a sentiment of all of the posts, whether they're more positive or more negative. And what we find is that people with higher friend exposure to COVID-19, their general sentiment goes down about 3.5% of baseline for a doubling of the friend exposure. Our final measure is whether people join one of these reopen groups. There are quite a few that have sprung up on Facebook, from Free Michigan, Reopen the Economy. And what we find is that people who have higher friend exposure are substantially less likely to join one of these groups. A doubling of friend exposure to COVID-19 cases is associated with a 0.09 percentage point reduction in joining one of these groups. That's a 7.35% decrease relative to the baseline probability. So overall, for all of our measures, we find that higher friend exposure to COVID-19 cases makes people more likely to post and less likely to oppose social distancing measures, less likely to join these reopened groups, suggesting that a social network is actually a really important source of information and opinions about the COVID-19 pandemic. So finally, in the paper, we repeat our analysis at the zip code at the CCTA level. We use safe graph mobility data, and we use the social connectedness or SCI data. The data is available freely for download at this website. And so we look at the zip code, including county level fixed effects to control for the general area. Of course, that has a much higher potential for confounds, doing it at the zip code rather than in the individual level. But we do think it is nice that our findings basically replicate in the sample of that is very differentially selected. These are not Facebook users, these are SafeGraph users, and so presumably there's some different selection, but we find very similar results. In addition, it allows us a little bit more insight into some of the mechanisms and to support the idea that this is voluntary reduction in mobility. Specifically, we find that people reduce their visits to businesses that we would think are essential. Reduce their visits to businesses that are non-essential, like the arts or entertainment or restaurants, food and drinks, but there's no effect on businesses that you would think are more essential, like healthcare or social assistance, or low contact, like parks. Similarly, we find reduced spending at places such as Starbucks, but no differential spending on places such as Amazon, where this should depend less on how people think about the pandemic. Okay, so let me summarize. We showed two key insights in the paper. The first one is that higher friend exposure to COVID-19 cases leads to more social distancing behavior by individuals. Exposure at the onset of the pandemic affects social distancing for months throughout the entire spring. It is not driven by the ability to work from home, and as the pandemic progresses, changes in friend exposure affect changes in mobility, further ruling out many possible confounds that we might be worried about. In short, it seems to be that friends and their experiences are important influence on health behavior, in this case, social distancing. Second, we show that higher friend exposure to COVID-19 cases leads individuals to post more about COVID, suggesting they're more aware, to post less about opposing social distancing measure, more in favor of them, and to be less likely to be a member of the reopened group, suggesting that friends influence beliefs about current events. And I think this last piece of evidence is particularly interesting in the context of the pandemic, because when we study the effect of social networks in other settings, and we've done this quite a bit, there's always an argument that, social networks are just an easier form of information, and it's not worthwhile for people to get information from other places. But here, people have really been bombarded with messaging about the pandemic. You can't really argue that someone has not had access or has not been aware about this messaging. And so the fact that friend exposure or friend experiences still have these very strong effects suggests that there's something else rather than the non-availability of other information, maybe trust, or maybe kind of trusting this information more, that makes people rely on their social networks when forming their opinions. Okay. Thank you.
Here we go. Okay, thank you. Thank you for your patience. Thank you, John, and thanks to everyone for being here and for having us on the program. I want to highlight first off that this is very much an interdisciplinary collaboration. So my co-authors are here, Lindsay Kobayashi, who is an epidemiologist, and Jessica Finlay, who is a gerontologist, and they're both at the University of Michigan. And our paper is called Caregiving in a Pandemic, COVID-19, and the Well-Being of Family Caregivers age 55 and older. So Americans are a significant source of unpaid or family care. I'm going to use those terms interchangeably. So even outside of parents caring for their children, for example, in 2019, approximately 40 million adults cared for a family member or a friend with a disability or a functional limitation. And nearly 40% of grandparents provide some sort of regular childcare support for their grandchildren. Additionally, 3/4 of adults with disabilities or functional limitations rely on care provided by family or friends. That's if they live at home, but also if they live in congregate or institutional settings, such as a nursing home or an assisted care facility. And so in this last year of our collective COVID reality, many studies have documented the disrupted and perhaps even catastrophic impact of COVID-19 on care provided in formal settings, including, of course, nursing homes and those who live in them and work in them, but also on those who rely on regular care from other health providers, as well as care provided in childcare centers and in schools. However, with the exception of parents taking care of children, which many of us I think are all too familiar with, there's been less focus on these family or informal care arrangements. And there's a lot of reasons to think that these critical family support systems are going to be severely impacted by COVID-19. So family caregivers often rely on supplemental formal care inside of the home or in the community. So for example, in the form of home health aides or other respite care, such as adult daycare. So these increase the risk of transmission, right? For example, many home care workers have multiple clients and are themselves at an elevated risk for COVID-19. So these formal sources of care were reduced or eliminated in the beginning of the pandemic, while many respite services such as adult daycares were shut down. So this leaves family caregivers potentially isolated and potentially having to take on more caregiving responsibilities. Meanwhile, the substantial share of families who supplement care, which is provided in a formal setting, were also probably increasingly unable to do so, given limitations on visitors and people going in and out of formal settings. Finally, a lot of caregivers themselves are older adults and at an elevated risk for severe COVID-19. And so, for example, grandchild care arrangements and other intra-household caregiving becomes a very high-risk activity, along with being directly discouraged by a lot of social distancing regulation. So in this, given the lack of evidence on family caregiving in COVID-19, in this project, we set out to provide some basic estimates of the magnitude of disruption to family caregiving arrangements during the initial wave of the pandemic. And we also wanted to know who was most likely to be disrupted, and if those caregiving disruptions were also correlated with other key disruptions to well-being that have been front and center during the pandemic. So specifically mental health outcomes, so poor mental health or employment disruptions. So we're going to approach this topic today using a national survey that was fielded in April and May of 2020. So the survey is the COVID-19 coping study, which my terrific co-authors put together, organized, and fielded incredibly quickly between April 15th and May 15th of 2020. And it was really designed to provide a snapshot of mental health and well-being of older Americans in real time. And they were kind enough to let me sneak in and add a couple of caregiving questions. And so the result of that is what I'm going to present here. So as I said, it's an interdisciplinary mixed methods design, the survey. There's a cross-sectional national panel, which I'm going to focus on today. There's also a longitudinal snowball sample where they were able to follow individuals over time. I'm just looking today at a national cross-section. It's an online survey, combination of closed and open-ended questions. It was designed to take approximately 17 minutes. So our national sample contains about 2,500 individuals. Sampling frame was based on an existing research panel. adults age 55 and older who use the internet. So, you know, take the representativeness of this with a grain of salt, as with any other online survey. Okay, so we asked a couple of caregiving questions. So specifically, we asked, in your usual life, so at that stage, usual life meant pre-COVID-19. We didn't think that our usual life would become COVID-19 at that stage. Do you provide regular caregiving to a spouse or a partner, elderly parent, a child, a grandchild, a grandparent or other relative, and another person with a long-term health conditions? And I want to stress again that this is a survey of adults age 55 and older, so we're looking at an older cohort here. And then we asked, in the past week, has the pandemic affected your regular care responsibilities? So have you provided less care? Were you unable to provide care? Did you provide more care, or did you take on new caregiving responsibilities? Okay, and so then the outcomes that I'm going to focus on today are going to be mental health and employment outcomes. So for mental health, we're going to use existing validated scales that are going to allow us to capture elevated mental health symptomology. So we're going to use an 8-item CSD depression scale, which I think is broadly familiar. And we're going to code a binary indicator for scoring 3 or higher on that scale. So that's going to capture high depressive symptomology. We're going to use a 5-item Beck anxiety inventory, coded similarly as an indicator for high anxiety, and a 3-item UCLA loneliness scale, again, as a binary indicator indicating high loneliness. We have a self-rated health, which is measured on a 5-point Likert scale. So we're going to code poor or fair mental health. We're also going to look at a couple of self-reported employment outcomes. So was your employment at all affected by COVID? Did you experience job loss or furlough? Are you working from home? And did you experience reduced hours or earnings? So I don't have time to share a lot about the literature, but I want to stress that the reason that we're focused on mental health and employment outcomes is because there are large and overlapping literatures that show that family caregiving can negatively impact mental health and can reduce employment along multiple margins. So let me just jump in and start showing you what the data look like. What did we find? About 23% of our full sample, of our full 2,500 respondents, reported being a caregiver in their usual life. So these are weighted means along with weighted confidence intervals, and I include the ends here just to give you a sense of the size of the actual sample that we're working with. It's not huge, but it is it is a national sample. So we found that about 47% of respondents were caring for a spouse or partner. Over 25%, 27% were caring for a parent. 22% are caring for a child. Another 20% are caring for a grandchild. And I want to highlight that almost 20% of caregivers are taking on multiple care roles, right? So they're taking on a number of these different roles. And in terms of caregiving being impacted by the pandemic, over half, so 52% of these care arrangements were somehow impacted. We found that 32% of caregivers found themselves either providing more care or taking on new caregiving roles, while 20% were providing less care or were unable to take on the caregiving roles that they previously had. So to look to take a look at these disruptions and to look at what kind of arrangements were disrupted, I'm going to show you this table, which gives you the rates of each caregiving type by disruption category. So we find that those caring for spouses or partners were much less likely to be disrupted, while those caring for parents or grandchildren were more likely to be disrupted, along with those in multiple care roles. And overall, we can summarize this to say, it looks like co-resident caregiver arrangements were somewhat less likely to be disrupted than non-co-resident care arrangements. If we break this out and look at demographic characteristics of caregivers by disruption type, and just to compare, this column here gives you the same characteristics, the same means, but for those who are not caregivers. And then so we find that overall, just broad summary of this slide is that disrupted caregivers are younger, they're more likely to be female, they're less likely to be white. They also are more likely to have been previously diagnosed with depression or anxiety. They're more likely to be working than both not disrupted caregivers or those who are not caregivers. And they also looks like they live in counties with higher COVID-19 prevalence, both in terms of cases and in terms of deaths. Okay, so the estimating equation we're using here to look at covariate adjusted relationships is very simple. I'm controlling for all of everything that we have in this survey that is measured pre-COVID-19, including age, gender, race, ethnicity, etc. I'm controlling for COVID-19 conditions in the county of residence, including state fixed effects that will capture any kind of state level restrictions, social distancing rules, etc. And so again, our outcomes are going to be our binary indicators for poor mental health, and then binary indicators for employment disruptions. So first, caregiving disruptions and mental health. So I'll show you the coefficients on our two key indicators, which is were you a caregiver pre-COVID-19, and then were you a caregiver whose caregiving was disrupted. So for all of our outcomes, depression, high depression, anxiety, loneliness, and then fair or poor self-rated health, caregivers who did not experience disruptions do not have elevated or better or worse mental health outcomes relative to non-caregivers. However, caregivers who did experience disruption also reported high levels of poor mental health. So they were 17.4 percentage points more likely to score high on our depression scale, 18.4 percentage points more likely to score high on loneliness scale, 15 percentage points more likely to score high on the loneliness scale. We see no change, no difference, I should say, in fair or poor self-reported health. And these differences between these coefficients, so between the effect of caregivers and caregivers with disruptions, are also significantly different. So caregivers with disruptions also exhibit poor mental health outcomes. Now we can look at this by disruption type. Right? Some of our caregivers provided more care, some provided less care, or were unable to provide care. So if we look by disruption type, and I'll show you these graphically just to limit the number of digits on the screen, right? So first, if we look at depression, we see again caregivers with no disruptions see no different mental health outcomes. Those providing more care and those providing less care see similarly elevated, are scoring higher on our on our depression scale. We see the same result for anxiety and the same result for loneliness, and no really strong relationships for fair or poor self-reported health. So overall, regardless of the disruption type, right, we see our caregivers who experience disruption score higher on these mental health indices, so seem to have poorer mental health outcomes during the pandemic.
5 minutes, sorry.
Okay. Thank you. So caregiving disruptions, now we turn to work disruptions. And again, I want to stress that all of these relationships, are purely associative. I'm not claiming any sort of kind of direct causality here. So here's the same table I showed you before. Now our outcomes are work disruptions, so any disruption, and then job loss or furlough, reduced hours, or working from home. And I'm estimating these on the subset of caregivers who are employed. So this is a much employed, I should say, prior to the pandemic. So this is a much smaller sample. So things get a little bit noisier here, and you can see that here, caregivers who did not experience disruptions look a little bit different than non-caregivers. In particular, they're actually less likely than non-caregivers to experience disruption. Particularly, they're less likely to lose their job. They are somewhat more likely to reduce their hours. However, caregivers who do experience disruption are also more likely to experience employment disruptions. In particular, they're much more likely to experience job loss or furlough compared both to non-caregivers and those who are caregiving but did not experience COVID-related disruptions. One more time, breaking this out by more care or less care. Right, we can see here that those providing more care, right, are much more likely to report that their employment was affected, and in particular, they experienced job loss and furlough, or they were working from home. Right, so if you're working less or you're working from home, potentially you have more time to devote to caregiving. We also see that those who were experienced job loss or furlough are also more likely to provide less care. One concern here is that our caregiving question didn't specify unpaid care. So we really wanted to kind of capture a very broad range of caregiving. So it's possible that, that we're picking up some paid caregivers here. I have an exercise, which I'll show you very briefly, where we drop anybody who's employed in a care or health or a health adjacent profession, and and we see the results for the positive correlation between more care and employment disruption remains the same here. We see less of a relationship for those providing less or no care. All right, so to conclude, we find that more than half of these family care arrangements were disrupted. Women, minorities, and employed caregivers are more likely to experience disruptions. And these care disruptions appear to be correlated with poor mental health among caregivers, along with work disruptions among caregivers. And so while this is a snapshot of the situation on the ground early on, this is looking at April, March, there was an AP NORC survey from August 2020 that also asked caregivers about their caregiving role, and they found very similar share of caregiving was disrupted. So suggests that these changes are at least semi-permanent. And the next steps here are going to be to look at the direction, or try to tease out maybe the direction of these relationships, maybe get a little closer to some causal relationships using larger longitudinal surveys, and think more broadly about what these results tell us, and what they inform us, how they inform policy interventions to target family caregivers more broadly beyond just the parent-child relationship. And just to finish off, because this survey had some great open-ended questions, we were also able to grab some great illustrative examples of the relationships that we're finding. So I'll just read this first one here, but if you want to take a look at all of them. So this says, my disabled daughter had 20 hours a week of licensed practical nurse caregivers. During the pandemic, I have had 0 hours of assistance, making my days very hectic while working from home, extra cleaning, extra cooking, etc. This person whose father is in a long-term care facility says, I've never prayed so much in my life. This last one is a woman who finds herself taking care of her husband with late-stage Parkinson's, says, I'm stressed and depressed. Okay, so that's perhaps a somber note to end on, but I think those quotes really illustrate some of these relationships that we're trying to capture and illustrate in the paper. Thank you.